Yeah, just by means of introduction, I'm going to read out brief edited bios and really encourage people to look at the full bios that John and Wesley are going to be putting in the chat room as I'm reading them out. So welcome to the panel and thank you so much for joining us, and thank you to John Reid for coordinating this panel and doing all the work, getting people together and organising it. So really appreciate that, John. So start off with you, John. John Reid is Professor of Clinical Psychology at the University of East London, as well as having worked in mental health service. He has edited and authored several books. You can look at what books John has written and edited in his bio, and published also over 180 research papers, primarily on the relationship between adverse life events and psychosis. So welcome, John. Professor Joanna Moncrieff. Joanna Moncrieff is a professor of critical and social psychiatry at University College London and a consultant psychiatrist at North East London Foundation Trust, and one of founders and co-chairs of the Critical Psychiatry Network. And Joanna is the author of many papers, many books. Please check them out if you're not already familiar. And of course, as we mentioned earlier, Joanna was the lead author of the recent review concluding that there is no evidence for the chemical imbalance theory of depression, which made headlines around the world. Welcome, Joanna. Brilliant to have you here. Stevie Lewis. Stevie is a UK-based campaigner and board member of the International Institute for Psychiatric Drug Withdrawal, and Steve is a member of the Withdrawal Services Working Group convened to define patient need for the implementation of Public Health England's recommendations for action. Welcome, Stevie. And again, please check out the full bios to find out more about these amazing people. Zev Faith. Zev Faith is a mad disabled queer transsexual psychiatric survivor and activist, and specialises in performance live art rooted in a number of themes, including alienation, social injustice, anti-capitalism. Find out more about Sev as well. And Dr. Rani Bora is a private holistic psychiatrist, wellness coach and speaker, and the author of the self-published book, How to Turn Stress on Its Head. She studied and trained in a number of integrative wellbeing and coaching approaches. She's a strong advocate for empowering patients, peer support and personal recovery, a special interest in de-prescribing, and brings her coaching expertise and knowledge into her clinical practice. Welcome everyone, and over to you, John.
Thanks, Jo. I just want to say I'm so glad there was a break after that last talk, because I was in tears. So give us a chance to manage my emotions, so to speak. So a couple of introductory remarks, and then we're going to ask our wonderful panelists to just talk a bit for 5 minutes or so about what they think is most important about psychiatric drugs, recent developments, where they are, or what they've been involved in, or what experiences they've had psychiatric drugs. We have a range of types of expertise, which is lovely. But we just want to stress that we're, in keeping with other remarks earlier, that we're certainly do not wish to in any way offend or do any damage, and I don't think any of us are saying there is no place under any circumstances for psychiatric drugs. In fact, those sorts of things should be up to people to make their own decisions. So we're not saying there's no place for them, as far as I'm aware. But I know we'll all agree on the fact that nobody should come off or reduce their medication on the basis of 50-minute discussion that we're about to have now. So what's the relationship? Why psychiatric drugs in the context of a festival about diagnosis? Well, we've already heard that the diagnoses have no reliability and validity most of the time, or very little reliability and validity. But one thing they do predict, about the only thing they do predict, is that once you've got a diagnosis, you are very likely to be put on psychiatric medication. That's possibly the only predictive validity they have, certainly in my own field of psychosis. If you get a diagnosis of schizophrenia, I would say you are 95 to 99% sure to be prescribed antipsychotics. So in terms of the size of the problem that we're panelists are going to be discussing, Public Health England recently did a very extensive review of the use of psychiatric drugs and found that 1 in 4 people in the United Kingdom are currently being prescribed the one of the drugs they reviewed, which included antidepressants, benzodiazepines, opiates, gabapentins, etc., didn't even include antipsychotics. We couldn't get them to include that. But 1 in 4 adults, which scares me. I mean, maybe some people think that's a good idea. In fact, there are some psychiatrists who'll argue there should be more people on it. We've still got a lot of people with diagnoses who aren't being treated. But from my point of view, 1 in 4 is quite scary. If 1 in 4 people really needed psychiatric drugs, then surely that's going to be telling us something about the state of our society at the minute. But scary as our world is, I really don't think 1 in 4 of us are in need of those drugs. And very tellingly, those figures vary by grouping. So women are far more likely to prescribe psychiatric drugs, in some cases twice as likely. Older people are very more likely to be prescribed drugs, partly because of the massive overprescription in old people's homes, or care homes as we call them these days. And people in deprived areas are more likely to be prescribed psychiatric drugs. So we're actually medicating the effects of poverty. Where I live in Newham, which is the poorest borough in London, if you're female, this is just statistically now, if you're female over 60 in Newham, you have a better than 50% chance of being on a psychiatric drug. So that's the extent of the problem. You would assume, given how widely they are used, and in keeping with the previous talk, we should remember to note that they are increasingly used with children. Given how often they're used, you would assume that they are the most effective and safest drugs in the medical repertoire. I think we're going to hear that isn't exactly the case. In most cases, they're barely better than placebo, and certainly have major adverse effects. And the last point to make is that this is the only field within medicine that you can be forced legally to take substances that may or may not be beneficial or may not be harmful, and that's a human rights issue. So that's enough from me. Oh, it's a great honor to actually be chairing this, and we're going to go through the opening remarks for 5 minutes or so, just alphabetically, which means, Rani, you're first up. Welcome.
Hey, John. I was hoping I would go last, but there you go. Someone has to get started, so I will. And I'm going to talk about my experience as a clinician and what I see routinely, and where I think the problem lies. And I will leave the research and to talk about studies to Joanna, because she's also in the panel. So I'll start with a story. I'll start with something that one of my colleagues shared with me some time ago, a psychiatric colleague shared with me. He said, Rani, it's like we have these medications, and like anxiolytic, antidepressant, antipsychotic, mood stabilizer, Z drugs. What we do is someone comes to us and we don't, we just pour all the, put all those, it's like we are a witch and we are trying to just, do something with them with some dose and, give another medication, swap another medication, and hoping that it would work. And I know that it might seem like, oh, why are you making this comment? But I see that in practice, and sometimes I think someone comes to us with lots of challenges in life and problems, childhood adverse events and personal circumstances and poverty, and they are presenting with symptoms that we could put in a box. But ultimately, it's like, okay, this is not working. Let's try something else. Let's try something else. That breaks my heart. And I have seen so many cases like that where, say they might come with only one medication, and say, for example, a primary care GP refers someone to us, and they have diagnosed someone with mixed anxiety and depression, and they might have started them on one medication, and then the GP will then try 2 or 3 different ones and say, okay, I can't deal with this now because I've tried this 3 antidepressants or for whatever. Now I need to send it to secondary care. And what I have noted is that as people stay with secondary care, the diagnosis keeps changing over the years, and also more and more medication has been given. But interestingly, I have noted that people don't seem to be thriving. People might be surviving. People might get some benefit, some relief from some symptom, but their life is, the same or maybe worse off. So that's something I have seen time and again, and I don't think I'm the only one. Maybe I'm speaking out here, but we have all noted that. Someone might start with a diagnosis of depression, and then later on they have bipolar disorder, and they have personality disorder, or worse still, they also start having physical health problems, like before they started on this medication, and there's this olanzapine, for example, as a mood stabilizer, or quetiapine as for sleep problem. They didn't have diabetes. Now, after 10 years or so, now they have got diabetes, they have got chronic fatigue, and so on. So that's a sad situation, and I do see that in secondary care. And I think the other challenge is that when people come to us, like say, for example, I'm a doctor. So when someone, when a nurse or a GP or someone says, you're going to see Dr. Bora or any other doctor, the expectation is that, oh, I'll be giving a diagnosis, or I will be reviewing the medication, or I will be giving them the medication. So that's what, when people might come to me. And I've also heard that people think, oh, because I don't want to take a medication, the psychiatrist won't want to see me. And again, this I don't know where this has come from, but maybe they have got experiences where they were told that if you don't want to take medications, I can't help you as a psychiatrist. So why am I saying all this? I'm saying all this because I have noted some dissatisfaction in my own practice when, in the NHS, where it seems there's an expectation from me as a psychiatrist to help someone, but then people are also thinking that, oh, the way I can help someone is by giving them a diagnosis, giving them medication, or changing the medication, increasing the dose of the medication, and that's how I can be of most help. And hands on heart, I know that if I try to do that, I won't be the most helpful, because I know that most of the practices are like that. And I'm also a coach, and I do a lot of well-being work, and I have always been interested in personal recovery, because part of my training was I got to learn from someone who was high on personal recovery. Some of you might know him. His name is Glenn Roberts. So he used to be my mentor as a junior doctor, and also as a specialist registrar. So I was very intrigued about personal recovery. I realized that medication, might have a role and might help some people, but there's so much more that, if you're just sticking to biopsychosocial, we are not helping any, we are not, exploring that. And when I came across the power threat meaning framework, and I think it really made sense to me. Like, rather than it, saying what's wrong with you, or if people ask what's wrong with me, we are going back and say, hang on, let's go back a bit. What has happened to you? And I know that my colleagues do that, and I know that we all do that as part of history taking. But I think we just stop at, oh, this person had trauma, that's it. And then we go to give a diagnosis or give medication. And I've noticed in my own practice that there's something that I think the previous, I only heard a little bit, but the previous speaker talked about us doing some work on ourselves, because if we don't, then you don't know how to help the other person. And I think it's especially true for us clinicians. If we don't embrace our own humanness, if we don't even reflect on our own challenges with with difficult experiences, difficult emotions, and we don't address those, I think it will be very easy to say, okay, let's just go for a quick fix, and so take this medication and you just have this therapy and that's it. What I have noticed is I'm getting more and more curious about. I'm not a therapist, so I don't try to do trauma therapy or or fix people. I try to fix people in the past. I've learned the hard way. What I have noted is that offering people that space, even when they come to a clinician, and you might think that, oh, you're a doctor or you're a nurse and this is all I do, but the more we show up as human, the more we offer that space to people open up in a very profound way. And I have had very recent experiences, actually 3 from yesterday, where they came scared of seeing a psychiatrist, or they thought they needed a diagnosis, they thought they needed a medication, but it all came back to something that happened and what happened to them. But we had a very deep conversation that went like from them thinking I need this medication to help me out with what I'm dealing with. By the time they left, because of me first of all embracing my own humanness, doing some work on myself, and I know there are plenty of professionals like me, and then allowing, not feeling phased or worried about someone's symptom, and knowing that, we can hold this in the space, and maybe teaching people not to get so scared of the experience, because what's happening is people are getting very scared of the experiences. They think that the only way to deal with this is they have been trying resisting, doesn't work. Then they try to fix it with drugs and alcohol or food or anything, and they think, okay, I do need this medication. When we as clinicians, we educate people, we educate ourselves first of all about our humanness. We educate ourselves about how we experience life, what how emotions can throw us sometimes, and we have this full-bodied experience, and we don't have to get so scared. We then also are able to hold a space for people no matter how they're presenting, and really give them hope, because then they see that they don't have to take all those beliefs and experiences as the absolute reality. There's some work to do around that. And I have seen people shift, and obviously I do other things. I'm also training to be a lifestyle medicine physician. I know the role of lifestyle in mental health, and how our sleep, our stress management, our exercise or movement, our food habits, our connection to other people, our taking substances, and reducing those, all of those can help, can have make a massive difference in someone's mental health. So when people come to see me, I might prescribe. I'm still a prescriber. I might still prescribe because I think there might be a role, but I take informed consent first of all. I also that explore, like, if they are presenting with a symptom, why are they having a symptom? Could it be the diet? Could be this? Could it be their sleep? Could sleep pattern? Could be that they're not managing the stress levels. Maybe they are re-traumatized by something happening. Whatever it is. And so we look at that, and my prescription doesn't look, is very different, because I do a lifestyle medicine prescription, and it might be like, okay, maybe you just need to do 5 minutes of walk or so. That tells me that I might be running out of time, but
Yeah, we're going to have to move on, Rani. Yeah.
Thank you. Just to summarize that,
Yes.
we don't have to do the way we have been practicing mental health. There's always there's opportunity for fresh start. So you guys are here in this event, and you are hearing something fresh, and so that's how I live it. There's always an opportunity for us to do something different. So I'll end there. Thank you.
Thank you so much. A lovely way to start. Moving on to you, Zev. Hi, welcome.
Hi, can everyone hear me okay?
I can.
Great. Hi, yeah, so I'm Zev. I'm a psychiatric survivor. I identify as MAD, and I'm also a psychiatric abolitionist. So yeah, I've had a very long history with psychiatric drugs. I was first prescribed them when I was 15 years old, and I'd been through, at that point in my life, I'd already been through just like quite a lot of trauma through kind of just like identity-based attacks. I struggled a lot in school. So I really struggled, and I'd been in CAMS for about 2 years at that point. And, they tried all their CBT and kind of all these different methods of telling me that there was something wrong with me. And then they settled on prescribing me Prozac, and very quickly on that drug, things kind of, kind of just like numb me out at first, and then kind of just like my mental state further deteriorated. And, based on kind of just like many factors going on, I started to hear voices, and from there I was then prescribed antipsychotic, on that antipsychotic I developed a hyperprolactemia, I started lactating, I developed akathisia, and I had a really negative, really horrific experience to this antipsychotic. So then they responded by doubling the Prozac and then switching me to Seroquel. And from there, my mental state deteriorated even more, and I tried to take my life. And then I ended up in an adolescence inpatient unit for 9 months, where I was traumatized. And from there, my mental distress was kind of just like then became the kind of defining point of my life. And I spent the next 12 years on and off almost 30 different types of psychiatric drugs. There was the SSRIs, the neuroleptics, the hypnotics, benzodiazepines, stimulants, mood stabilizers, gabapentinoids, tetracyclic antidepressants, NDRIs, SNRIs, SSNRIs, and they all had their own unique set of disabling side effects, or rather just their effects, as they kind of functioned in subduing and silencing my madness, but they never offered me relief from my profound psychic suffering. And so then in 2017, I decided I kind of like had enough, and so I went into a detox. It took me like 9 months to started kind of tapering off, because I really wanted to get off of these drugs. And I tapered off of I was on very, very high dose of Valium, stimulants, and pregabalin. And so I had to get to a certain amount before they would like admit me into a detox. But once I was in the detox, they took me off everything in about 2 weeks, and I suffered seizures. I went through just like really, really horrific withdrawal symptoms, and then ended up on another antidepressant. And from kind of there, that's when I kind of just like discovered I went back to school, and I discovered kind of just like critical psychiatry and abolition and mad liberation and all of this stuff, all this great stuff. And I, through peer support, learned how to do a harm reduction taper. So I spent the last 3 years coming off of a duloxetine, and through using the harm reduction method, that is 10% of each subsequent dose every 2 to 4 weeks. And it took me almost 3 years, in which time I kind of just like I suffered, even during the harm reduction method, I suffered like really, really severe disabling withdrawal symptoms, which is something that just like I didn't know about. I tried to come off them I've come off of on and off many different drugs, and never kind of realized, and I'd never kind of like put 2 and 2 together, that the withdrawal effects was having such a profound effect on my mental state. And through these harm reduction peer support networks, I got off. And so I'm kind of I see myself as kind of like psychiatry's worst nightmare now, because I'm medicated, I'm mad, and I'm free from these drugs. I've been free from 3 months now of all of psychiatric drugs, and I never want to go back. And now I'm at kind of 29 years old, I'm learning who I am, and I'm learning kind of just like what I can be without these drugs, without these labels, and really stepping into mad liberation and abolition, and figuring out kind of, because withdrawal was something I kind of never taken account. I was always told that kind of, if you're suffering without these drugs, then it's relapse, or it's proof that you need them. But really kind of stepping into my own madness, and realizing kind of like experiencing distress doesn't mean I need to medicate it, when I've never experienced any kind of just like positive things from these drugs. And so that's kind of just like my story with psychiatric drugs.
Thank you, Zev. Thank you so much. I'm so sorry you went through such a terrible time, and welcome back to the world of the living.
Thank you.
And it's lovely to have you with us. I can see Stevie nodding away at she's been through some similar things. I'm assuming Stevie and Joanna will touch on this, but just in case they don't have time, what you described reminds me to remind everybody that when and if you are ready to come off the drugs that you might be on at the moment, it's really important to do it very slowly and with a lot of support. The idea that you can get off these sorts of drugs in a couple of weeks is really not the case at all, and it can take months or years. It has to be done very slowly and carefully with lots of support. Okay, we'll move on to Stevie. Welcome, Stevie.
Well, thank you very much. And when I hear a story like Zev's, I'm just amazed, firstly, at the strength of the human spirit, how you got through that and you're still going through that. And it's, you know, once you've stopped withdrawing from a drug, it's not all over. You know, you've not properly rejoined the human race. Your health isn't 100% back to normal, as I know, but all the drugs that you were put on, I was just on one, and that was terrible enough. So to hear about someone who has suffered so much with so many, I just I'm in awe, frankly. I was given one Seroxat, paroxetine. And this was a long time ago. This was way back in the 90s, at a time when it was part of what was called the Defeat Depression campaign. And GPs through the National Health Service were being targeted to try and reduce depression. And it appears that I got caught in the middle of that. The drug companies weighed in with help with this campaign. And the public moved from an understanding that depression and anxiety were something that happened to you, to it being a chemical imbalance, because this is the story I was given back in late 1996, a chemical imbalance story which Joanna and Mark Horowitz and Ruth Cooper have finally properly put to bed now. And the public is going, wow, we thought that was true. And apparently many psychiatrists are going, well, no, actually, we knew it was just a myth. We knew it was just a story. But I went to the doctor with something that I now know is just normal woman's menopausal, perimenopausal symptoms. And it's quite, it makes me very angry to now, when I see on the television celebrities and people coming forward and talking about their menopausal symptoms, and I'm going, but I was told I got a chemical imbalance in my brain, that I was on the edge of I was told I was on the edge of a nervous breakdown, and actually it was just a normal part of my aging process. So anyway, I became a campaigner, and locally to start with, and then fortunately having the opportunity, because of the growth of social media, to go from just writing to my local MP, who was a complete waste of time, frankly, to petitioning the Welsh Senedd, the Welsh Parliament, because I live in South Wales, being involved as the campaigning grew wider in information that went to Public Health England for the review in 2019, which John mentioned, and then finally outwards further internationally, to be able to moan internationally about antidepressants, because antidepressants is the drug I was given, and so it's I just bang on about one thing. I'm a bit of a one-trick pony on that point, from that point of view. And it's interesting to hear from Zev's story how antidepressants, the Prozac and that type of thing, they're a gateway drug into, because some people develop quite severe adverse effects very early on. We've been given antidepressants, and they become a gateway as GPs and psychiatrists add in more drugs to combat the well, they're called side effects, but they're not actually. They're adverse effects as your body is adjusting to the drug as you're taking it. Some people's bodies adjust very well, and some people's bodies don't adjust very well. And that's when other drugs are brought in, and you end up with a kind of a sort of polypharmacy. John asked for us to think about what's important currently as far as psychiatric drugs are concerned, and the points I wanted to raise, I suppose, are the things that I've been campaigning about really from the start. My voice on that hasn't altered. Continuing to get GPs, because all the work is done in the surgery, in the prescriber's surgery, whether it's psychiatry, but generally in the UK, it's GPs that dole out antidepressants. So important for GPs to be now retrained so that they recognize withdrawal. In 2017, 2018, when I started campaigning, GPs didn't even see withdrawal. They only saw relapse. But now they see withdrawal. Now we have new NICE guidelines, which were published last year, one in April 2022 and the other in June 2022. And these NICE guidelines now give quite good and amazingly good, actually, detail about how to withdraw from antidepressants. So withdrawal is recognised as existing, finally. Guidelines aren't as detailed as they might be, but they're a huge improvement and something that, 4 or 5 years ago, I could not believe could exist. So GPs being retrained so they understand these guidelines, that they understand withdrawal exists, and they understand how to taper people from their drugs. And something which I see now coming as a direct consequence of our campaigning on antidepressants, which is deprescribing. We are starting to see more and more deprescribing, particularly with the elderly. John mentioned it's the elderly and women who are very much put on drugs like antidepressants. Deprescribing, if people aren't adequately trained to understand how slowly people need to come off these drugs, then it's going to be a bit of a car crash out there with more and more people suffering from withdrawal.
Thanks, Stevie. Finally, on to Joanna. And Joanna, can I just let you know, there's understandably a lot of the questions coming in from the people taking part are about your recent chemical imbalance paper. So if you can squeeze in, we've got a.
I was going to reflect on that, actually.
Okay. So we have. I just want to acknowledge Sally, a mental health student nurse, Worcester, who has asked, will this have any impact on prescribing?
Good question. Good question. I'll come to that. So first of all, I just wanted to pick up on something Stevie said, which I think is key. So yeah, everyone has been indoctrinated into this idea that depression and other mental health problems are due to chemical imbalances in the brain. And that idea was very deliberately put about to squash our underlying common sense ideas about what emotional problems actually are, what they consist of. It was started up in the 1990s at a time when prescribing drugs for mental health problems had got a very bad rep, because the country, the Western world was awash with benzodiazepines, which had been revealed to be highly addictive and difficult to get off. And so pharma needed to change the narrative. Everyone knew that benzodiazepines were just doping you up. They needed to change the narrative. They needed to persuade people that they had to take these drugs not to numb them, not to drug their feelings away, but to rectify their underlying brain chemical problem, brain chemical disease. And so that's because that message was so successful, our paper showing that actually the research doesn't support any link between serotonin and depression was such big news. But what I really wanted to reflect on is what that means about antidepressants and the sort of reaction that we've had. So basically, psychiatrists did not want us to talk about what this means for antidepressants. Quite obviously, this raises questions about what antidepressants are doing if they're not doing what they were first thought to be doing. And yet, literally, we were expected to just say, oh, well, we found this finding, but antidepressants probably work in some sort of similar way, so don't worry about it, carry on regardless. That is what the psychiatric establishment wanted us to say about this serotonin paper. And as you can see, I feel very, very angry about this, because this is just carrying on the lie, the duplicity that people have been fed for the last few decades. What our paper on the serotonin theory of depression means about antidepressants is that we cannot assume that they work by targeting some underlying biological mechanism that produces the symptoms of depression. The main theory about these mechanisms that justified the use of antidepressants was this serotonin theory. There's no evidence for that, and there's no consistent evidence for any of the other numerous speculations, and that's what they are, speculations about the possible biological basis of depression. And therefore, we have to consider that antidepressants, we have to think about them in a different way. We have to consider the drug-centered model, which is what I've been, putting forward all my life, which is the working life, which is the idea that psychiatric drugs are psychoactive substances that change the normal state of the brain, change the baseline state of the brain. I know normal is a difficult word, but the state of your brain when you've taken a psychiatric drug is not the same as the state of your brain when you haven't taken it. And they are not working on some underlying mechanism. They're not reversing some underlying abnormality. They're not normalizing things. They are abnormalizing things, if you like. And because they're changing the normal state of the brain, they change our mental states, our feelings, our behaviors, some of them more subtly than others. And it's these mental changes that impact on the difficulties that people are having, the depression or anxiety or psychosis or whatever it is. And in some situations, I feel that those drug-induced mental alterations can be useful. In some situations, they may be better than what people are going through. But when we think about drugs like that, we realize that changing the normal state of your brain every day, day in, day out, for weeks and months and years is not necessarily a good idea. And it may indeed have harmful consequences. And we've heard about those from Zev and from Stevie. We now know that antidepressants like benzodiazepines, like barbiturates, like all of these drugs that we use, cause the brain to change so that when you stop them, you get a withdrawal syndrome. So they cause what we call physical dependence. And we also know there are other long-term consequences, some of which can persist when the drugs are stopped. So they are changing the brain, and sometimes the brain really struggles to get back to normal when you stop them. Hopefully, it seems that over time it does, but it can be a long process, as Stevie and Zev have explained. So, yeah, so I just think it's really important that people know about that, and I feel I feel so shocked and so disappointed by my profession that they have basically tried to stop. They are obviously trying to stop that message getting out to people. And that means that they are basically trying to stop people from having the ability to make properly informed decisions about what they take into their bodies. And that is shocking. And I'm just trying to rectify that, as we all are here today.
Thanks, Joanna. Would any of you like to come back and comment on anything that any of your fellow panelists have said? Just jump in or add anything.
I would just say that it's so common even now. People say, but I need to fix my brain chemicals, right? And this is what I hear. So but doctor, I need to hear, it's my brain chemicals. And even if they are not my patients and I am talking to someone just on a social level, I still hear that. And so you can see that Joanna, Mark, and the others have done this amazing work. And we don't know, and it would be great to have this understanding disseminated to the whole world, and it's getting there. But I think it needs people to stand up. It takes each of us to stand up and do it our way, because if we are waiting for someone else to spread the news, like a GP, say for example, to spread the news or something, it might take ages. And I think collectives like this, we are coming together today, and this is an opportunity for again us to share with anyone who would hear us. But people are desperate to hear something different, for sure, because people have realized that, okay, I've been taking this for my chemical imbalance, how come I'm still not balanced after all these years? So that's an interesting question to ask as well.
Okay, thanks, Rani. One of the questions that Stevie, was that an in-breath?
Well, it was a sort of in-breath, and I've lost what I was going to say. I think I was thinking about the irony, actually, of the situation that we're in, and I guess caused by the drug companies wanting to accelerate their sales, and they've been so successful in that. But one of the things that has happened, because the medical profession has embraced this, and continued leading to people to believe that their emotional distress is due to a chemical imbalance, that now you have a situation where the National Health Service is, must be becoming overwhelmed with the number of people, or the doctors with the number of people sitting in their surgeries thinking, I'm upset, I'm angry, I'm grieving, I'm hurt, and the only person that can help me is a GP, because it's a chemical imbalance in my brain. And the cost to the country for that, I mean, we've already seen research that's been done on the cost of the prescribing and over-prescribing of antidepressants, particularly, and the continued cost in time and effort for GPs, because they are deemed to be the only person to solve our problems. And it's not true.
Just a little 5-minute time check. Thank you.
Okay, Sav, would you like to come in?
Yeah, just like one more thing is, so I think kind of like these like drugs, as drugs on themselves, they are just like morally neutral, but it's the way that they are prescribed that is dangerous, and because they are kind of so weaponized by psychiatry.
Okay. So we've got a few minutes. So go, Joanna.
And I just wanted to add to support what Stevie was saying, really, is I think we so desperately need a non-medical space for in which to help and support people who are going through various forms of emotional distress. That is what doesn't really exist. And surely it would be pretty easy to create it.
Yes, well, we heard about how easy it is within schools and within school life for somebody to just take the time to listen, whether you're a teacher or a professional, non-professional. I think we are actually being de-skilled as a society. The fear that I don't know enough, I might say the wrong thing to my distressed relative or friend. I need to get them to a doctor. I think that's one of the most damaging things that we're all facing. We just all got to remember that those spaces can so easily be created everywhere, and they're actually being squashed by our mental health services, I think, despite there being many people who went into mental health services to do precisely that. That's what they wanted to do, sit and listen and be supportive and kind, which is what we know heals things. So I'm going to, anybody wants a last word? We've got about 2 minutes left. Sorry, it's all been so rushed. And I'm going to prioritize Stevie and Zev, if that's all right, in terms of people who have been through it, but give them the first chance to last words.
I will just say very briefly, for anybody struggling with withdrawal, I understand how bad it is and how bad you feel. Take it very, very slowly, and your body will heal. You will get better. You may not be as good as you were before, because I can't say that I am. But you will get to a point where life is good again without drugs. Take care.
Thanks, Steve. Zev, would you like to say anything?
Yeah, Stevie said it just like really well. yeah, that is possible to. I do want to kind of like echo that. Kind of that it is possible to get off of psychiatric drugs if that is something that you want, and yeah, you do it kind of slowly, one day at a time, with a good support system. And the kind of the advice we always hear is kind of like talk to a doctor about it, but actually the best person to talk about it with is someone who's been through it and gone to the other side.
Indeed.
Thank you, Zev. Rani and Joanna, 30 seconds each. Rani.
You do not need to manage your feelings. I think that was a really profound one. And the narrative competencies are the one. So you don't have to be a doctor to be able to help someone. You can, you can be just a layperson and still be still support people hugely. So that's what I would say.
Thank you, Rani. Joanna.
Just if you're thinking about taking a drug for a mental health problem, be really informed, make sure you know as much as it is possible to know about it, and be careful.
Thank you all. I will, or we will put up various resources in the chat, the various online support groups, which are doing a wonderful job in the absence of us professionals doing very much. We'll put a few of those up, and also make sure you're all aware of the International Institute for Psychiatric Drug Withdrawal that Stevie and I are on the board of. We'll put that link up, as well as lots of resources there. And that institute also needs your support. So you forgive me putting a plug in for helping the institute. Hopefully it can be helpful to you as well. So thank you all to all of you, Joanna, Stevie, Zev, and Rani, and thank you, Joe, for all the work you do bringing us all together on these wonderful days.